College, Jaipur. So today we have a faculty talk on clinical urodynamics. We will start the session with Saraswati Vandana.
Saraswati Namastubhyam Varde Kamarupini Vidyarambham Karishyami Siddhir Bhavatu Me Sada.
Again, welcome to our teaching session. And so I will just introduce the speaker today. So today we have a talk on clinical urodynamics by none other than Dr. Sanjay Sinha. And I think everybody knows Dr. Sanjay Sinha. He is professor and senior consultant urologist at Apollo Hospitals, Hyderabad. He has been the chairperson of USI guidelines on urinary incontinence. He is the regional editor of SIU Journal, associate editor of BMC Urology, avoiding dysfunction section. He is in the editorial board of Indian Journal of Urology, International Urogyn Journal, current Bladder, Dysfunction. And he has been also in the urodynamics committee of the 7th International Consultation on Incontinence. So most welcome, Dr. Sanjay Sinha, to our teaching program here. Thank you very much for accepting our invitation. Today we have two special invitees with us. Dr. Shirish Yande. Dr. Shirish Yande, are you there? So he must be there. He must be. So he would come or join us soon. Again, he's Dr. Shirish.
Yeah. Hello.
Okay.
Hi.
Hello.
Hi,
Hello, sir. So Dr. Shirish is a chief urologist and director of academics at Ruby Hall Clinic, Pune. He has a special interests in urodynamics. He runs an exclusive urodynamic lab in Pune where he performs and reports almost 1,000 cases every year. And he has a special interest in functional urology and has recently set up a center called Crystal Center for Urinary Incontinence and Urology in the city of Pune. And he is also part of the multidisciplinary committee to look after children who have meningomyelocele. So welcome, Dr. Shirish, to our teaching program. Thanks for accepting our invitation. And then we have Dr. Anita Patel. Dr. Anita Patel, again, doesn't need any introduction. We know in most of the conferences, we can see her in our urology forum. She's trained at Mumbai KM Hospital. She has been a consultant urologist for the last 22 years. She has been the visiting consultant and teacher at MPUH Nadia. And she was also holding a position in KEM Hospital in 2017-80. And she has been in faculty in over 50 national and international urology conferences. And she is also a panelist in urinary incontinence guidelines by USI in 2019, and also neurogenic bladder by SIU in 2016. So most welcome, Dr. Anita, to our teaching program. So now I would request Dr. Sanjay Sinha to please share his presentation and start the program.
Thank you, Dr. Shivam. So my first interaction with Dr. Shivam was a long time ago. I don't know whether he remembers it. He came down to Sanjay Gandhi Institute as a trainee from Jaipur. Do you remember that, Shivam? And so we were kind of contemporaries, and we used to go to each other's centers to get some
92, 93 maybe, yeah.
Precisely. So I was, I think, in my first year when you actually came down. So you came in, I think, in 93. And to Sanjay Gandhi Institute. And so that was my first interaction with him. And it's been a pleasant and a very nice friendship that has developed over the years. Greetings to the Department of Urology, SMS Jaipur. You are pioneers in urology and in PCNL and a whole lot of other specialized subspecialties of urology. Greetings to Dr. Anita and Shirish And coincidentally, both of them are actually panelists from the USI guidelines panel for urinary incontinence. Very appropriate that you've got the right faculty with us. And I'm sure they'll be able to add a lot of important stuff to what I talk about. So let me start by 5 illustrated cases to show how urodynamics can actually get positioned in our clinical practice. Examine a 60-year-old woman who has unresponsive clinical mixed incontinence. Should we offer her stress incontinence surgery to salvage her incontinence or botulinum toxin? How do we decide? A young man with voiding difficulty, is he a candidate for bladder neck incision? A man with spinal cord injury with a low PVR, no clinical infections, uses abdominal strain to void. Is it okay to allow him to void? That way. A child who underwent fulguration for PUV who has bilateral hydronephrosis. Does this represent ongoing bladder dysfunction or is it just a memory change? Or a 70-year-old woman who has refractory voiding difficulty. Is this an underactivity? Can she benefit from some therapy and so on? So what are we going to discuss in the next 30 minutes? Briefly, what does the urodynamics trace represent? How do we recognize good quality? What are important artifacts in the urodynamics? What are clinical urodynamics applications for voiding and storage dysfunction, for neurogenic lower tract dysfunction, and pediatric voiding dysfunction? Clearly, if I've got to discuss this, and I actually have 40 minutes, this is clearly going to be an abbreviated discussion. And I guess each of the things that I discussed today could be in their own right a full hour's discussion. So let's first look at the underlying principles, quality control, and some basic findings. So the basic setup for a urodynamics looks like this. You have 2 tubes placed into the bladder, one for filling the bladder and the other for measuring the bladder's pressure. You have 1 tube placed into the rectum, which measures by convention what we call the abdominal pressure, and the pressure recorded from the bladder is by convention known as the abdominal pressure. You have a filling system through which a pump directs a pre-specified fluid at a pre-specified rate into the bladder. And then when the patient passes urine, you have a uroflow meter, which records the pattern and rate at which the urine comes out. And if you put fluoroscopy for a video urodynamics, there would be a CR imaging. So essentially, the background for all this is that you record the vesical pressure from the abdomen. You record the vesical pressure from the abdomen. You record the vesical pressure from the bladder, you record the abdominal pressure from the rectum, or you could record it from the vagina, but it's usually not a very reliable recording from the vagina. And in patients who have had a colostomy, you could do it from the colostomy. And you are really interested in the subtraction of these 2 values, which is called by convention the detrusor pressure, PDET. Sorry for that mix-up. The rate at which we fill the bladder is typically in milliliters per minute. And to fill at a physiological rate would take hours to do. So you need to typically fill at supraphysiological rates. You would like to fill at about 10% of the expected capacity in milliliters per minute. So let's say if you expect a capacity of 300, then filling at 30 milliliters per minute is usually okay. And these will all be supraphysiological. In terms of what's physiological, if you take the body weight in kilograms and divide it by 4, then that is considered the upper extreme of what could potentially be a physiological flow in that individual. Now, one note of caution, if you are doing urodynamics in a patient who has a neurological lesion T6 and above, please monitor the blood pressure because you can get catastrophic autonomic dysreflexia once in a while and it can kill the patient if you're not careful. So let's look at a trace here. And this here, the upper line is P vesicle. That's the time axis. You have red for rectum. You have the PDET value, and which is a subtracted recording, as I said. From here to here is all up to this point, the filling cystometry, and then towards the latter part is all the voiding cystometry. So that's the PDET. This is the flow channel. That's the voided volume. Here you can say is the place where the micturition command has been given. That's the voiding pressure. You can see here the voiding contraction, the flow. You can see that the EMG often, but not always, shows an increase in activity as the bladder fills up. And then when you give the command to void, right at that moment, you can see just before the detrusor contraction happens, actually the sphincter becomes silent. And then you have the flow occurring. So the silence of the sphincter typically happens before the onset of the detrusor contraction. And so the change in activity of the EMG sphincter is more important than absolute values. So we are more interested in relative values, not these absolute numbers that are seen here. So the urodynamics matrix essentially consists of looking at voiding and storage aspects of lower tract function, and you want to look at both the bladder as well as the outlet. So what are some of the general principles? The urodynamics should be interactive. You want to duplicate the patient's symptoms, and you need to be cautious with incidental findings. Sometimes you can get, for instance, detrusor overactivity in a child, or adult for that matter, induced by the test. You need to do real-time interpretation or have somebody do the real-time interpretation. For instance, if there is staccato voiding where you get a kind of intermittent flow, you need to see, was there some other reason why it happened? Is it truly dysfunctional voiding or something else? Sometimes asymptomatic findings might be crucially important, and this is very true for neurogenic lower tract dysfunction patients where storage abnormalities and so on may be very important even if they're not symptomatic. You want to report or at least be prepared with what the report is going to be before the patient leaves the suite. And as I always say, the urodynamics should not be regarded as a test. It's a three-step consultation process where you first assess the patient, then the urodynamics, and then reassess the patient to give a final answer as to what's to be done next. So let's look at certain points in terms of quality control. So how do we recognize whether a study is actually of a good quality? So a few things here. So the resting pressure is the first thing you want to look at, and the resting pressure should not be zero when you start. So you can see here the abdominal and the vesical pressures are not zero. These pressures, transducers are zero to the atmosphere. And because they're zero to the atmosphere, there's some finite pressure in the abdomen, even at a baseline resting state. So that baseline resting pressure is what is reflected here when you start the study. So even before you start filling, there is certain pressure, which is the resting abdominal pressure, which will vary depending on the position of the patient, and more importantly, depending on the body morphology. We don't have good standardization for children. These values which are given here are for adults. We are in fact currently in the process. The functional and female urology subsection is actually doing a study across 5 centers to try and get data for the first time globally on these resting pressures in children. You can see the initial P det should be on the other hand close to zero. So when you subtract these two, it should be close to zero, and this is the one that we are interested in. Now, you might ask me, how does it matter whether you have zeroed here to these two transducers to the atmosphere or to the patient? Even if you zero to the patient, it won't make any difference to the P det values. But there are certain situations, let's say, for instance, if you're doing an abdominal leak point pressure measurement, where when you look at the abdominal pressure, your recordings would be grossly under-recorded if you had zeroed to the patient. The other thing you can notice here is periodic cough. So there's a cough done in the beginning to start with, and you can see a reasonably good subtraction. There are periodic coughs in between, a cough at the end of filling, at the point where the patient is told to void, and a cough at the end of the test to make sure that the transducers continue to function well at the end of the study. The other thing to look at is the fine trace match. So if you look at the fine pattern here, the fine pattern seems to match each other. And this fine pattern, which you see here, can be because the patient moved a little, is talking, and so on. And when you get this match of the fine tracing, it reassures that both the transducers are working perfectly and continue to work perfectly as we are doing the test. The micturition command should be recorded either electronically or by a manual label. That's important because sometimes it's difficult to differentiate whether you're talking of a phasic contraction or a volitional void unless it's actually been labeled so. Right. Now let's look at some common artifacts. And I'm going to show you 4 or 5 different artifacts here. Now, this looks like these are phasic contractions, and we'll come to this in a moment. And it seems that the pressures towards the end of filling are rising because this is the P det line. But if you look more carefully at the abdominal line, you find that the abdominal pressure is showing a wavy pattern. Now, if you remember, I told you that P det is derived by a subtraction of P abdomen from P vesicle. What that also tells you is that you can't get a valid deflection in P det without a corresponding deflection in the vesical channel. So if you find any pressure change on PDET, look at the vesical channel. And if you don't find something there, it's got to be an artifact. So you can see here there's spontaneous rectal activity, and this is not detrusor overactivity, it's an artifact. And what looks like reduced terminal compliance is in fact there's a drift of rectal pressure as the patient's as the bladder is being filled, because there's a leak at some point, or there's an air bubble or something interfering with the rectal pressure record, and that drift down is reflected in what looks like poor compliance. So it's not really poor compliance, because you can see the vesical pressure is a flat line, almost a flat line, very little rise towards the end. Some other things you can see, if you fill too fast, this patient has been filled very fast, the pressure goes up dramatically. And this poor compliance has almost certainly overestimated the pressures. And you can see the sign of that, is clue to that, is you stop filling and you find the pressure going down. And this accommodation which you get in pressure on stopping the filling is a sign that you are actually filling too fast. And you can see the same thing happen here, that when this patient didn't void, the bladder was filled a little bit more, and it seems as if there's a volitional contraction. This is not a volitional contraction. This is additional filling done. And you can see again that same rise. And then when the patient tries to void, all these deflections that you see here during voiding, these are not volitional contractions. Such sharp changes in pressure can't happen because of detrusor, because detrusor is a smooth muscle and it takes time for smooth muscles to recruit. So whenever you see sharp rise and fall in pressure like this, it has to come from a skeletal muscle, not from a smooth muscle. And these are actually abdominal strain artifacts because of subtraction errors. Let's look at some of the basic findings that you can get. Now we know during storage, ordinarily the bladder pressure should be close to zero or flat line. So if you don't get a flat line close to zero, it can take one of two forms. You can either get a phasic rise and fall, which you are seeing here. This is called detrusor overactivity, or you can get what's called poor compliance, which is a progressive rise in pressure. That's called poor compliance. So these are two cardinal findings. These are not the only findings, but two cardinal findings during storage. Clearly, there are some situations where storage sensations can be critical, for instance, in bladder pain patients and so on. But these are two important findings in terms of patient health, upper tract function, and so on. So what is compliance? Compliance actually reflects change in volume per unit change in pressure. We hence express it as ml per centimeter of water. And typically we take these points between which we are measuring the pressure as the end fill and the beginning of filling. But you could theoretically take any 2 points and measure the compliance between them. So here, for instance, if I filled 140 ml and I've had a pressure of 40 or so, it means roughly, let's say that is like 3 ml per centimeter water. So it's a very poor compliance. The other findings relate to the voiding function, and you can see here two important findings. This is a patient where after the patient has been given the command to void, is a very high pressure and a very slow flow. This combination of findings is classical of obstruction. So to draw an analogy to somebody sitting in a room and trying to push a door open to go out, if the door is not opening, it could be because of two reasons. Either the door is jammed or I'm not able to push the door effectively. So this is a situation where the door to the bladder is jammed. And if the door is jammed and if I'm normal, you would expect me to push very hard to open the door. And that's precisely what the bladder typically does. So a normal bladder will push much harder than it normally would to try and open the outlet if there's an obstruction, and you'd get a slow flow despite that. So that's bladder outlet obstruction. And this, on the other hand, is a very poor detrusor contraction. So once the micturition command is given here, there's barely a contraction. You could even call this an acontractile detrusor. Most of these look like subtraction artifacts. So these are some of the cardinal findings that you could get in a patient in whom you do urodynamics. So now let's look at some of the applied urodynamic findings in certain conditions. And also let's try and answer the question relating to those 5 clinical conditions I told you about. So first, female urinary incontinence, and what are the possible urodynamic findings. So I'm not going into the theory of when to do the urodynamics and so on. But if typically you would plan to do an invasive urodynamics only at the point where you are looking at invasive therapies. That's what our guidelines, also the USI guidelines states. So what are the potential findings that you could get when you do urodynamics in a patient with refractory urinary incontinence? You could get urodynamic stress incontinence, detruso overactivity with or without incontinence. You could get urodynamic mixed incontinence. You could get cough-associated detruso overactivity with incontinence, urgency with detruso overactivity, reduced compliance, alternate diagnosis like avoiding dysfunction, and normal. So you could have a patient who has overactive bladder wet, where the patient has normal findings, and that doesn't exclude a diagnosis of OAB wet. So take a look at this patient, and let's say, for instance, she has refractory mixed urinary incontinence. And this is where we have been filling the bladder up to this point. And you can see here straight away that there is a high pressure, there's a phasic contraction during filling, and the patient has leaked a substantial amount of urine. It's like 250 ml of urine which has come out with this phasic contraction. With this phasic contraction. So this patient has detrusor overactivity incontinence. But thereafter, in this patient, a cough stress test has been done. And in the cough stress test, in the beginning, this patient does not leak. So you can see here, the catheters are in place, the patient doesn't leak. And typically then we make these patients stand up. And then if they don't leak at that point, we remove their urethral catheter, and that's what's been done. And hence you can see a sudden drop in the vesical pressure when the catheter has been removed. And when you do that, now you can unmask stress incontinence here. So not all women will leak during a stress test with a catheter in situ, and hence you need to remove the catheter in these women if they don't leak, if they have a history suggestive of stress incontinence. So if there is a woman who has this kind of a pattern, and you find high pressure detruso overactivity incontinence, you can see very large volumes of incontinence. And if the symptoms match up to, it seems to be primarily a mixed incontinence with the urgency component dominating, you might consider actually botulinum rather than stress incontinence surgery, because botulinum is simple and can be reversed very easily, unlike a stress incontinence surgery. Right, and remember, you need to zero to the atmosphere, because you can see here now that when you record the detrusor leak, the abdominal leak point pressure, if you have not zeroed to the atmosphere, then this 20 centimeters would be the discrepancy in your recording of the detrusor of the abdominal leak point pressure. What are the criteria for defining intrinsic sphincter deficiency in such a setting? Intrinsic sphincter deficiency, if the abdominal leak point pressure is less than 60, this patient has, has severe ISD. Between 60 and 90, it's a mild ISD. You can get a clue to ISD by a clinical test called the empty bladder supine stress test, where in the lithotomy position, after having voided urine, a woman is asked to cough. And if she leaks, you find a trickle of urine happening. That is suggestive of ISD. And that's a clinical test for making a diagnosis of ISD. Sometimes you can get what's called cough-associated detruso overactivity. And you can see here two different types of cough-associated detruso overactivity. This is a patient in whom the leak happens with the cough, but there is CADO. Here you can see the leak happens both with the cough as well as with the phasic contraction. This is another type of CADO. So you can get various different types of cough-associated detruso overactivity during the test. And it's important to recognize these so that you can offer the right treatment to your patient. The USI guidelines state that invasive urodynamics may be omitted in women with uncomplicated stress incontinence. And while I will not go into details of this, suffice to say that you have to be very meticulous in your application of the definition and very scrupulous in making sure that every aspect of the definition is adhered to. That onus is on us. And any woman who doesn't perfectly fit into that definition should undergo a urodynamics prior to surgery. Invasive urodynamics is also recommended in men and women with urgency incontinence prior to invasive therapies by the USI guideline. But remember, other international guidelines do not recommend this. And the reason for the USI guideline to recommend this with a level 3 evidence and grade, a weak grade of recommendation is primarily to exclude other diagnoses. We feel that botulinum and sacral neuromodulation are both invasive therapies which are expensive with potential for harm. And it's important to exclude other diagnoses which are not uncommon, like avoiding dysfunction. So it's not to make a diagnosis, but it's to exclude a diagnosis. So findings of DO or lack of finding of DO during the test does not make a difference to the outcome of botulinum injection or sacral neuromodulation. Next, let's look at men with voiding difficulty. And if you look at the non-invasive tests like a Uroflow, it's not perfect. The Uroflow with a cutoff of 10 milliliters per second has a specificity of about 70 and a sensitivity about 50%. Residual urine about 50%, 50% positive and negative predictive value with a 50 ml cutoff. We know that patients may be severely obstructed despite no residual urine, and patients may have an enlarged prostate without an obstruction. What are the indications for doing urodynamics? This is not an exhaustive list, but essentially patients who have an age, patients who are young, or patients who are in the geriatric age group, patients with very large residual urines, patients who have a high flow but still complain of voiding difficulty, patients who have an underlying neurological diagnosis, storage symptoms dominant, not able to produce a valid uroflow with adequate volume. Such patients should have a urodynamics prior to surgery for the bladder outlet. Let's look at this young man. So I gave you one problem where there's a 49-year-old male who has voiding LUTs and you are not sure what the cause is. And this is the urodynamics trace. Once again, that's the P vesicle line, the P abdomen line, that's P det, the subtracted line. This P det you can see here during storage is normal. Voiding, there's a high pressure and a slow flow characteristic of obstruction. You can see here that this patient also shows EMG activity during voiding phase, but I must caution you that EMG is the least reliable part of the test. And there are several times where the EMG is not, it doesn't give us the right answer. So over the last 2-3 years now, we have almost stopped relying on EMG at all in such settings. And if we at all suspect that the patient has a dysfunctional void, we would invariably in such patients do a video study. And you can see here in the video study, I'll just bring it to the part where this patient has voided. And you can see here that as this patient voids, you can see the bladder neck is closed. So there's a very high pressure and you can see a closed bladder neck. The prostatic urethra is not dilated. And this is characteristic of primary bladder neck obstruction. So although the EMG seems to suggest that it's a dysfunctional void, this is not a dysfunctional void. This is a primary bladder neck obstruction. And this patient should do extremely well with a bladder neck incision. There is another concept that I would like to introduce in relation to all this in the male patient, and this is primarily meant for the elderly male, but it's applied very often to the younger male as well. In this patient, you can see that the P det Q max is about 120, the Q max is about 6, and there are two indices that we often calculate: the bladder outlet obstruction index, which is P det Q max minus 2 into the Q max, and the bladder contractility index, which is P det Q max plus 5 into Q max. And in this patient, you can see the BOOI is 108, and anything above 40 is a severe obstruction. The contractility index is 150, which is a strong contraction. Having said that, these indices are far from perfect. Our own data suggests that the median bladder contractility index in about 1,600 patients whom we have just reported, it's under consideration in a journal, was about 98 or 99, if I remember correctly, telling us that half the patients in whom we end up doing urodynamics actually have contractilities in the weak contraction zone. So that's too blunt an instrument to take any decisions. In fact, if you look at these two indices, you have two levels, or you can say grades of abnormality for the outlet obstruction index, BOI. So you have 20 and 40 with equivocal and severe obstruction, and one category of normalcy with the obstruction index. But you have two categories of normalcy with the contractility index, 150 strong contraction, 100 to 150 normal contraction, but only one subcategory of abnormality with the contractility index. So this is unsatisfactory. We are currently in the process of a Delphi study with 3 other international investigators to actually look at this to see whether we should be having sub-classifications of the contractility index. We'll next go to neurogenic lower tract dysfunction. And let's examine one patient who's 31 years old with a history of anorectal malformation, denies major voiding difficulty, has episodes of urgency and urgency incontinence, 1 to 2 febrile illnesses in a year, constipated but is able to manage. He's ambulatory with normal upper tract function and keen intellect. And let's look at his urodynamics trace to try and answer whether the trace on its own can tell us whether this patient is safe or not. Now, if you remember, we discussed very briefly that storage pressures are important. So we know that storage pressures and voiding pressures function both is important for the upper tract. And in this particular patient, it appears that the storage pressure is good. So again, look at the PDET line. The storage pressure looks low. That's PDET. The patient has a normal capacity, normal compliance, no neurogenic detrusor overactivity. There's some spontaneous rectal activity. The end fill pressure is about 10. That's a place where it's given the command to void. Acontractile, abdominal strain, no PVR. You can see the patient empty the bladder. Looks like a bladder which is safe, right? Is spontaneous voiding okay? The answer here is we don't have enough information to take a decision. You need more information in this patient. And I'll tell you what, more information. We needed some more information in terms of imaging of this patient. And especially we need to do in any neurogenic patient, a video study or combined with an MCUG. So let's take a look at this patient's video study. And let me again scroll down. And you can see here, this patient shows reflux as the bladder is being filled up. So these pressure estimates are an underestimate because the patient is actually refluxing into the kidney and there's a large volume reflux. The ureter is grossly dilated. See that, a large volume reflux. So all this pressure that you're seeing is a gross underestimate of the true pressure. And when you go to the voiding phase here with abdominal strain, you can see there's a dilatation of the prostatic urethra and there is some reflux into the prostatic glands, all suggesting that when this patient does the Creed's maneuver, or the Valsalva strain to try and void, this patient is actually having a dyssynergic pelvic floor activity, and it's not safe for the patient to do what he's doing. And this is actually reflected in more information, which I can share with you now on this patient. This patient actually came with a creatine of 5, has no residual urine, but bilateral hydronephrosis. So this patient clearly is not safe. So this is a good point to introduce a couple of more concepts related to this. The first concept is detrusor leak point pressure, and then the detrusor leak point volume. Now, in patients in whom you are doing a urodynamic study in a neurogenic setting, when you fill the bladder, sometimes you can get a progressive rise in pressure, as you can see in this patient. And at some point, by the side of the catheter, fluid starts leaking out. When that happens, the volume at which that leak happens is the detrusor leak point volume, and the pressure at which this leak happened is the detrusor leak point pressure. This detrusor leak point pressure, in a sense, is a reflection of the outlet resistance and the compliance, or you can say the elasticity of the bladder wall. So if there's a high leak point pressure, it suggests that the kidneys are going to get exposed to high pressures when this patient is not on CIC. So if the patient is just leaking out into a receptacle, diapers or whatever, or in a controlled manner in the toilet even, but when this patient leaks out at pressures which are potentially damaging for the kidneys. So detrusor leak point pressure and detrusor leak point volume combined can give us some idea about safety. Let's look at storage and safety. Now, there were some thoughts that a pressure of 40 centimeters is a cutoff for what's safe. Please banish that thought. We know that pressures much lesser than 40 may not be safe. Any pressure above 20 should not be accepted. That doesn't mean that a pressure of 10 is safe. And I just showed you in that patient, just the case that we showed 2 slides earlier. A low pressure doesn't imply safety, but a high pressure clearly implies lack of safety, right? One more concept related to storage is what is called the neurogenic detrusor overactivity leak point pressure. Now, NDO just implies that the detrusor overactivity is in a neurogenic setting. And you can see here that NDO is occurring as we are filling the bladder, and the pressure at which the patient leaks is called the NDO leak point pressure. This is a relatively newer concept, and there's very little data to show how this pressure is associated with upper tract damage and prognosis of the patient. We don't really have good quality data on this. So you can see here NDO leak point pressure. Is it 100? No, not really 100 is the lowest pressure at which the patient leaks. So in this patient, the NDO leak point pressure is actually 48 and not 100 because the lowest pressure at which the patient leaked with a phasic contraction was 48. The pattern of pressure rise is important, and you can see here 2 children, one in whom the pressure rises rapidly, but not to the extent that it rises in the other child. But in the other child, the pressure rise is much slower through all of filling. And especially if this patient is having a CIC volume, let's say of 250, and this pressure is starting to rise after say 300, this patient is likely to be safe despite a high leak point pressure. And this patient may not be safe despite a relatively lower leak point pressure. So just the detrusor leak point pressure is not important. You need to add information information with regard to what's the average CIC volume and the pressure in the bladder at that volume. And what this tells you is you can't manage a patient with neurogenic bladder without a CIC diary. So you must have a CIC diary in all these patients. One last case study before we go to the next subject, and this is on another patient who's 17 years old with a history of a fall and an injury to D11, D12. And this is a patient who has a classical finding, which we must again look at. And this is the classical detrusor sphincter dyssynergia. Let me show this to you. And you can see here a grossly abnormal bladder morphology, a hugely dilated prostatic urethra with reflux into the prostatic glands. And this is classical detrusor sphincter dyssynergia when this patient makes an attempt to void. So this patient is clearly unsafe. And if this patient is allowed to void for any length of time, it is almost mathematical that this patient would end up with damage to the upper tracts. So some crucial lessons for the neurogenic subgroup: patients with high-risk diagnosis must have urodynamics. And what are the high-risk diagnoses? Spina bifida, spinal cord injury, and urethral malformation. And then any other neurogenic patient in whom the urodynamic findings or the clinical findings are high-risk findings. Urodynamics must include or must be combined with contrast imaging of the lower tract, ideally video, but you could do a UDS with a VCUG, and that's an absolutely acceptable alternative. Ability to void is not important, neither is ability to hold. What is important is whether the voiding and the storage are safe. And detrusor leak point pressure or any urodynamic finding for that matter is not enough to take decisions regarding safety. So urodynamics can tell you lack of safety, but can't tell you that the patient is safe. That's a clinical decision based on the overall assessment. A few words about PUV and hydronephrosis. Let's look at a patient who has PUV and hydronephrosis and continue. And the question is the hydronephrosis due to an ongoing bladder dysfunction? And you will get some clues from the symptoms in this patient, the progress when you longitudinally follow up the patient in terms of morphology. Look at the MCUG, which is the current MCUG of this patient, match it up with the pre-op MCUG. And although this looks bad in terms of the urethra, this urethral dilatation is much lesser than the urethral dilatation pre-op. This patient has good voiding stream. So this patient who is voiding well shows improvement in urethral morphology, but shows deterioration in bladder morphology. So you can see the bladder looks worse, the urethra looks better, and that's reflected in this patient showing upper tract changes which are progressive. And this patient has progressively increasing detrusor pressure as the bladder is filled up. There's a poorly compliant bladder along with phasic detrusor contractions, both of which are bad for the upper tracts. We'll next go to voiding dysfunction in women, and I think that's the last subgroup. There are various causes for voiding dysfunction in women. It could be an underactive detrusor, dysfunctional voiding. Dysfunctional voiding implies that there's dyssynergia of the striated sphincter or pelvic floor muscles in the absence of a neurogenic etiology. Most patients are supposed to present with staccato voiding, but as we have published before, many patients don't show staccato voiding and actually can show a flat curve as well. You can have primary bladder neck obstruction, a relatively less common diagnosis. Anatomical obstruction, far less common. And I continue to believe that many patients are overdiagnosed with strictures. Unsuspected neurogenic dysfunction, all these are potential reasons for getting voiding dysfunction in women. And the relative proportion of these two diagnoses obviously is different between a man and a woman. The criteria for diagnosing obstruction in women is also different, and that's because of differences in lower urinary tract and pelvic floor physiology between men and women. And so we would label a woman obstructed at a far lower pressure compared to men. So if the voiding pressure is above 20 with a flow which is slow, then in a woman, we would call this a bladder outlet obstruction. Having said that, a patient who's voiding at, let's say, 25 centimeters of water with 10 ml per second flow rate, although obstructed, also has an underactive detrusor. But underactivity is even poorer in terms of definition in women, and we really don't have any data as to what to call underactive in a woman at this point of time. Take a look at this woman who has refractory voiding difficulty. And you can see here the storage phase looks fine. That's the voiding phase, micturition command. And there's a somewhat elevated pressure and a slow flow. The voiding pressure is about, these are 20 marks. So this is about 55 or so centimeters voiding pressure and a flow about 7 or 8. So she is obstructed based on all criteria. Let's look why she's obstructed. And again, let me scroll the video here to the point where she's voiding. And you can see here that she has a dilatation of the proximal part of the urethra as she voids. So the bladder neck opens well. She has a dyssynergic striated sphincter pelvic floor activity, because of which she is having bladder outlet obstruction. So she is, in the absence of a neurological etiology, this would be a dysfunctional voider and needs to be managed as such. One other common condition in women, pelvic organ prolapse and voiding difficulty, typically happens in prolapse which is beyond the hymen or the introitus. And simply doing the urodynamics both with and without a pessary, you can see how much improvement in voiding function can be seen here. And if you see this kind of improvement in voiding function, it reassures you that putting back the prolapse is likely to resolve the woman's voiding symptoms if this happens. This is not always demonstrable in all women, but it certainly reassures you. And if this doesn't happen, it's probably best to prognosticate the woman that it's possible that your voiding problems might not resolve after the prolapse is put back. One final question which we are often asked as urologists and is the question as to whether the chronic renal damage that you see in a patient is secondary to the lower tract. And an ancillary question is the storage phase more important or the voiding phase more important in terms of upper tract damage? And if you look at all textbooks, let's say indications for doing a TURP, for instance, in the indications, you'll find hydronephrosis. So it has been kind of assumed that obstruction causes hydronephrosis, and we know that the mechanism by which upper tract gets damaged typically is the lower tract should typically produce hydronephrosis before damage to the upper tracts. So as far as the first part of the question is chronic renal damage secondary to lower tract dysfunction, in the absence of any hydronephrosis, and the caveat is that the patient mustn't have had a catheter when you are assessing the patient, in the absence of hydronephrosis, upper tract damage is unlikely to be secondary to the lower tract. So the sequence of events should be lower tract dysfunction, development of morphological changes in the upper tract followed by deterioration in renal function. So in a chronic stage, you don't expect upper tract damage to occur in the absence of hydronephrosis with the lower tract dysfunction. But as I said, the important question is obstruction important or is storage important? And this is a question that we've tried to answer actually for the first time, surprisingly, because this is such a common issue in our wards, but somehow has not really been examined in literature before. And this is again from the same body of 1,596 patients, which we reported. And you can see these are 8 different categories of patients with storage and voiding problems. And these are the predicted probability of hydronephrosis. And you can see here that the predicted probability of hydronephrosis is much higher in patients who have storage abnormalities compared to patients who have isolated obstruction. So in fact, in our patients, storage abnormality had the highest odds of developing hydronephrosis, but isolated bladder outlet obstruction was not associated with hydronephrosis in our patients. Underactivity was patients who were having underactivity seemed to be protected unless they developed large PVRs. So those patients with underactivity who developed a large PVR again went on to damage their upper tracts. But if they were underactive but with low PVRs, then again their upper tracts were safe. Right. So as I said, so if I flip this around, so patients who come to us with severe storage disorders at urodynamics, so whether it's neurogenic, not neurogenic, or whatever, if they have severe storage disorders, those are the groups of patients in whom you need to be very careful, because such patients can damage their upper tracts. And you must have seen this. There are patients, for instance, they're young men with primary bladder neck obstruction who come to you with a creatinine of 5. And you do their urodynamics, you find that they've got bad outlets, but they have consequentially also developed bad storage, or that they have very large residuals and they have damaged their upper tracts. So the storage is extremely important. If you find bad storage in any patient in whom you do urodynamics, very important to counsel these patients that if they don't follow themselves follow up very carefully, you might end up with renal deterioration. So you can use this to mathematically predict which are the patients who are actually going to develop trouble in the long run. So with that, I will stop sharing my screen and let me.
Thank you. Thank you very much, Dr. Sanjay. And that was a very nice way of presentation on different case scenarios. So there's more, I think, practical way of presentation, which will benefit our residents also a lot. So now I would request our invitees Dr. Shirish and Dr. Anita. So to begin with Dr. Shirish, if you have any comments on what was presented here, and besides that, what do you think is the role of urodynamics in your clinical practice, and how do you take it? So first, begin with Dr. Shirish.
Yeah. You want me to comment on what Sanjay said?
Yeah, if you have any, comments.
Be merciful.
Yeah, but Sanjay and I always have some subtle differences in thoughts. But I mean, I won't bring it up here because basically this was a very, very highly demonstrative exposition, and it has been almost everything has been explained. But what was your second part of your question, Shivam? What is the role of urodynamics in what?
In your clinical practice, what do you think is the role of urodynamics, and where do you actually do urodynamics?
Okay, I think that's a very broad question to answer. But see, I mean, urodynamics is done in our institution as at a request of the referring physicians, clinicians, usually urologists and gynecologists, essentially. Really speaking, I do understand that not all patients who come to us actually need urodynamics. They need a lot many more non-invasive investigations before urodynamics is done. But yes, I mean, I'll give you an example. For example, a patient with a cerebrovascular accident has got urgency incontinence, and is invariably such patients are referred to urodynamic departments to find out why they have urodynamic, why they should be incontinent. Obviously, you find the patients with cerebrovascular. Am I heard there? Yeah.
Yes.
Cerebrovascular. Yeah. Okay. What I'm not able to see any screen. Yeah. The patients who have got cerebrovascular accident are once they settle after the cerebral stroke period is over, they settle into a detrusor overactivity usually with a very synchronous relaxation of pelvic floor. So they don't have any asynchronous movement of the sphincter, and they fairly develop a good amount of ability to have a synchronous pelvic floor. So they don't have anything called detrusor dyssynergia, and they are fairly safe bladder. All they have is that they do not perceive the urgency, but they have urinary incontinence all the same. So all these patients do not actually need urodynamic evaluation. They could be managed very well without it. On the other hand, we have patients with, say, neurogenic dysfunction with meningomyelocele, for instance. Now, these patients have to have preemptive urodynamic evaluation without the patient complaining of any symptom, without the parents have any complaint. For example, parents feel the patient is voiding very well and I have no problem. But these are the patients who are potentially have disastrous storage mechanisms of the bladder, as Sanjay has explained. And these are the patients who require preemptive evaluation by urodynamics at all means, and starting very early in life. That's what it is. The number of other issues where patients have neurological bladder dysfunction, which you don't realize. For example, patients with a tethered cord syndrome. Suddenly you find a young man, young boy or a woman or a girl develops unexplained urinary symptoms at the age of 13 or 14, and we don't know why this is developing those symptoms. Now, this is where the problem comes. When the cord tethering has occurred, you may not have noticed any signs to define the cord tethering. They may have subtle external signs on the skin, but you may not even notice them. But these are the patients who would definitely require urodynamic evaluation to find out what are they going to be in the future, and they can have substantially serious complications in the future. So just to give you an overview, there are indications where you should do urodynamic in these cases, and there are indications where you need not do urodynamics in these cases. Does that answer my question?
Oh, yeah. Sure. Thank you, Dr. Sirish. I would request now Dr. Anita to give her comments, and then we will come to the questions.
So, am I audible?
Yes, perfect.
Yeah, because there's some work going on in the vicinity and I could barely hear what was being spoken in the session. So I have landed up putting earphones. So I was just making sure I'm audible. By Sanjay. And I don't think I'm going to comment on anything that he said. One peculiar thing which I have seen happening when we're talking about rectal pressure and the subtraction and the technicality is if the trace is not making sense and if you are seeing an unusual drift in the pressure trace, just make sure that the bladder line is connected to the urethral catheter and the rectal is really connected to the rectal catheter. This may sound stupid, but I have seen interchange of rectal line being, the rectal transducer being connected to the vesical line and vice versa. And as the compliance deteriorates, the rectal pressure starts rising, not the vesical, because you've connected the wrong line. And the entire urodynamic tracing goes completely topsy-turvy. And you have to witness that to actually realize how horrible the whole trace can look. So I thought I'll just make a mention of that. And Sanjay, it was wonderful. You should use the analogy of a door not opening. I wonder if it's given in any textbook or any paper anywhere, because that's the exact analogy that I use for my patients. That imagine you have to leave the room and the door is not opening. If the door is wide open, you will walk out like a king or a queen. If the door is partially open, you will use all your strength to open the door. And if you still can't, you will have to squeeze your body to get out of the room. And that is exactly what happens in a good bladder with an obstructed urinary tract. So it was very interesting that Sanjay should use the same analogy. I think we should move to the question answer so that we can do some meaningful discussion.
Thank you. Thank you, Dr. Anita. So there are a few questions in the chat box. One is related to pediatrics. We know it's maybe a challenge to do a pediatric urodynamics. And so the one question was, what is the earliest age at which we can do a pediatric urodynamics? And the other, what special precautions or what special preparations you do for doing a pediatric urodynamics?
So in terms of the age, you can do a urodynamics at any age. So if there are children who have high risk disease, for instance, spina bifida or open spinal dystrophism or anorectal malformation, they must have urodynamics as early as possible. So the moment they've recovered from their initial surgical interventions, neurosurgical, pediatric surgical interventions, that's the time to do it. So you are literally looking at urodynamics within weeks or months of birth. And there are situations where even a 6-month delay or a 12-month delay in a child with a bad bladder is enough to for the child to develop irreversible renal damage. I have children 1 year old with just 12 months of delay with a bad bladder where there's irreversible CKD already because of the lower tract. So must assess as early as possible, and you can get storage-related phase information at any age. Voiding phase information may be difficult in the small child, but most often you can surmise regarding voiding based on the clinical constellation of findings, talking to the parents, looking at the ultrasound scan, or just by clinical judgment. But the storage phase, and I just showed you storage is much more critical. In any 24-hour period, we pass urine for maybe 10 minutes. The rest of the 23 hours and 50 minutes, we are storing urine. Hence, what happens during storage has a much more profound impact on the kidneys compared to what happens during voiding. So we can get all that information even in a newborn. Now, in terms of what preparation is to be done, I think the most important thing with the urodynamics in children that I have found is that once in a while, you get a child who develops severe sepsis post-UDS. And it's critically important. And my feeling is this anecdotal, I haven't studied it, we should study, and I hope at some point I can give you data on this, that children who have upper tract dilatation or who have chronic kidney disease related to the lower tract are particularly at higher risk. And one such episode can give rise to the child in the ICU, AKI on CKD and so on. So number one, always use prophylaxis in a child. Number two, at the end of your study, always empty the bladder. That's true both for the MCUG as well as for the urodynamics. When you fill the bladder, always fill at a rate which is slower than, slow. So I mean, obviously, what is slow? So what is to me slow may not be slow to you. But as a rough guide, don't fill at more than 10% of the expected bladder capacity for the child. If you find that you're filling and the bladder pressures are going up, slow down or stop. And if you stop and you find the pressure coming down by that accommodation that I told you about, that's a sign that you're filling too fast, cut down the filling rate. If you start getting phasic contractions, stop. Again, restart with a slower filling rate. So all that can help getting the most reliable pressure information. Make the surroundings as comfortable as possible for a child. Have one parent when you're doing the test along with the child. If the children are capable of understanding, and I'd say any child who's 5-6 years probably can understand a bit, it's best to explain to the child what you're going to do. Tell them that there will be some discomfort. Telling a child that there won't be discomfort and then finding that they find pain or discomfort during the test is not the best way of gaining the child's trust. And especially if you want avoiding phase, is going to be very difficult. Give the child, as usual, the same privacy that you would afford an adult. And you have to be patient, give enough time. Make sure that you get a Uroflow done up front, very important. Many of these children will not have an Uroflow done from before, especially if it's a non-neurogenic setting, let's say a PUV child. So these are some of the things that I would look at during doing. Some of these children will have severe constipation as a part of their problem. Make sure that the bowels are empty, because if the bowels are very full, then you won't get perfect information in terms of the bladder pressures. We know there's a crosstalk that happens between the other pelvic organs and the bladder. So those are some of the steps I would say are issues related to a child. Any other thing you'd like to add, Shri?
But the most important problem here is how to manage a small child, right? So that's what probably the.
Oh, right. There was a question about anesthesia.
Whether you would like to give some analgesic or some kind of sedation to these children, because they are not manageable.
Right. So I think the first is, if you have got more than one person in your team, the most experienced person handles the child. That's the first thing, because your confidence in doing the test makes a huge difference to the child's ability to cooperate. The other is, most often, earlier, I'd say a few years ago, there were many patients in whom we would give some amount of, trichloril, or we would pedichloril, or we would sometimes put the tubes under anesthesia. Over the last few years, I've almost not done it at all. So almost invariably, you give a little time for the child to settle down. Don't try and immediately do the test after you put the tubes in and so on. And most often you can actually manage and get the child to cooperate. So usually it's not an issue, but if you really do need to give anesthesia, you can do the test at the time when the child is just coming out of anesthesia. And don't use muscle relaxing agents and all. It should be fine to be able to do the test.
So how often you do in pediatrics?
Every day.
Every day. So there's usually
almost every day. Almost
the smallest child is usually do in infants also.
Yeah. Even newborns, I just told you.
So there's no problem as such.
So in fact, the newborns won't give you problem. The problem happens with the slightly older child, not with the newborns. But as I said, most often it's possible to get the cooperation. You have to be patient, and you can't have when you're doing this, you can't put a time pressure on these children. That really makes it very difficult. So your technician should have. So actually, we have 2 urodynamics machines in 2 adjoining rooms, and so we can manage these kids and all. Otherwise, it's very difficult in one day to handle the volume that we have. So with children, you can't have a time pressure.
And one thing about as you said about the video urodynamics, and that video is quite important in many of these scenarios, right? So, but many of us do not have a video urodynamics. We have.
That's fine. Yeah.
So how important is to have a video urodynamic to get a proper result or proper?
So if I would, for the residents, go back and look at the USI functional urology subsection talk that Anita gave. She gave a small 2-minute capsule on the use of imaging. And maybe I should allow Anita to answer this question.
Yes,
Anita, you'd like to take that?
Dr. Anita? Yes.
Imaging.
So video urodynamics.
Yeah, so you're specifically asking about pediatrics, aren't you, Dr. Shivam?
I think he's asking in general.
Not pediatrics. It's just for general.
Video.
How important is to have a video urodynamics?
Okay, so first of all, it would be ideal if anybody with interest in urodynamic has access to video urodynamics. So that is the best option. If you do not have it, make sure you have adequate pre-urodynamic imaging available so that at least you filter out those who may need either a simultaneous imaging or who at least need a separate pre-procedure MCU. So that very often gives you a lot of anatomical information, so that even if you didn't have a simultaneous imaging, you can correlate the urodynamic findings with, say, for example, the case which Sanjay showed, the anorectal malformation, which was allegedly safe pressure as per urodynamic criteria, but it wasn't a safe pressure because everything which was being filled in the bladder was actually going in the upper tracts. So the volumes were misleading, the pressures were misleading. But let's imagine if we had this MCU at least beforehand, if not simultaneously, our interpretation of the urodynamics will be far better. So best situation would be to have it simultaneously. If I can't have it simultaneously, and if there is dilated upper tracts known to me before the UDS, and in pediatric, I must always have a sonography before doing a UDS. If it is known to me, and if I know I don't have access to a video, I will insist on a pre-procedure MCU. I think that's the best that I can answer it, so that I make sense out of my urodynamic trace by marrying my trace to the previously available MCU findings. That's the best that I could answer it.
Thank you. I think yes. So if you do not have a video, at least have a urodynamics MCU.
And the other thing that we also do sometimes is we don't have to have superimposed images of the MCU on the UDS screen. Even if you have facility of doing a simultaneous cystogram, but the two images don't have to be superimposed, as long as somebody is handling the X-ray C-arm and there is a UDS going on simultaneously, as long as the images are correlated with the trace, I think that is all that you need. Now, this is where in pediatric practice, this may be the only situation where I may want a little sedation. And I'm sure both Sanjay and Shirish would agree to that, because to have a child who's exceptionally cooperative, not moving so that we get excellent images during a urodynamic can be a little tricky. And in pediatric practice, it is the storage phase that we are extremely concerned about. And in that, we don't need a child who's conscious and is aware and volitionally voiding on command. In fact, in many pediatric situations, we don't need the voiding cooperation so much. And this is where I may want a little sedation so that I get good imaging while the urodynamics is going on. So that may be one situation.
Somebody has started sharing. Anyway, yes. So what type of sedation do you use usually in children?
I don't. I almost never use any sedation in last so many years. I have never used, but if I were to use simultaneous video, I made it very clear. Yeah. That may be the only situation in a non-cooperative child. Yeah. And these situations are very far and few. So I almost never use any sedation.
Presentations by Paul Abrams, I remember I heard him saying about that even in UK, 90% of the urodynamic studies are not done properly. Yeah. So it would be, we don't know what would be the proportion here in India. So because we have very few centers where they do a dedicated, where you have a dedicated person who is doing a urodynamic study. So what do you think? How should it be taken, particularly in our country? Because if it is not done properly, then the whole purpose is lost. So this is
right. So in terms of imaging, what Anita said, perfect. And so I would say actually there are only two groups where imaging is usually not required. And that's the elderly male and the regular urinary female stress in urinary incontinence. So a female urinary incontinence and the elderly male are the two groups where you don't need imaging. I would say most of the other settings, you actually need imaging. And the thing is, as long as you recognize the need for imaging and you combine it usually before, but even if it's not before and patient has come to me, I would still do it after and not hand a urodynamics report at that point. So obviously the patient has to come back. But you need to be able to recognize that you need imaging. Now, in terms of what setup to have, I think for a regular urology practitioner, maybe not everybody needs to have a urodynamics. There's nothing worse than having a poor quality trace done. Because, you know, all of us come across this situation where somebody's already had a urodynamics 1 week before and no information is forthcoming from it. It's a bad quality study, and then you are at a loss what to tell the patient. So I think unless somebody has some real interest in that particular field, it's probably best not to get into the field at all, and trust to have a good colleague you trust. If you're doing regular work or regular urodynamics, it's fine. If you want to really work in the field of functional urology, then you should think about video urodynamics at your center. But otherwise, I think for most centers, having a regular urodynamics with or without MCUG should be fine.
Right. So,
Shivam, may I add something to what Sanjay is saying?
yes, Dr.
Yeah, I think quality control is extremely important. If you look at Paul Abrams's initial lectures, they all were concerned about the quality control all over the world, for that matter. Because he does go and lecturing around all over the world. And I think what happens in India today is majority of the centers are handled by postgraduate students, and I don't think they are the right people to be handling them. What we found as urodynamicists for all these years, a good technician whose job is to ensure that the recording is absolutely perfect and accurate. That's all that is to be done. Rest of the things are done by us, because we can then find out how to correlate the symptoms with the patient's findings, stresses. But a good technician he has to ensure that the recording has to be absolutely accurate without any flaws. And that is what every urodynamic center should ensure. A technician who is trained properly, and he just ensures that thing. That's all that is required. The rest of them we will of course manage. But I think, yes, a good department of urodynamics should have a good technician, and of course a dedicated personnel like a urologist.
Dr. Sanjay, do you think it can be managed
afterwards?
Or because urodynamics is something which requires a constant communication also with the patient, and a lot of things would depend upon that also. So I think, what do you think? A clinician should do it, or a technician can?
No, so there are two skills in a urodynamics. There is the technical skill and the clinical skill. So if you ask me today to do a urodynamic study, I don't think I can do it for you. Right? I've lost the skill. There many years back when we started off, I trained my technician by sitting on the machine myself. But today, if you ask me, I don't think I can do it. So there's a technical skill and a clinical skill. You, as a clinician, you need to have the clinical skill. The technical skill the technician needs to have, and you have to supervise and make sure that he does it the right way. And my technician now over years, he knows exactly what I want. So if you are, whoever is supervising or in the room in the test must be aware of the interpretation of the findings. So my technician understands, and hence he can do. My nurse understands. So I've got a technician and a continence nurse, and they both can do it independently. They understand. But so if the technician doesn't understand, then you need to be there. So, if nobody understands during the test, then you're in trouble.
Anyway.
And that's one point, Shivam, that as Sanjay said, is 3-step performance of urodynamic studies. The person who takes the history first generates urodynamic questions, and that has to be a clinician. It cannot be a technician. Okay. So we must understand what we are looking for. Are we looking for detrusor overactivity? Are we looking at detrusor function? Are we looking at safety of the bladder? Are we looking at the mechanism of incontinence? But that's urodynamic questions must be generated and clearly defined before urodynamic can actually be performed. So you tailor every investigation to the patient's needs, and then the role of technician comes to know what exactly is to be done in this particular case. Do you follow? Do you agree, Sanjay, with this?
Absolutely.
Right. So you need a dedicated technician plus a clinician who is supervising it. So because otherwise you may not have a good interpretation.
And Dr. Shivam, a dedicated checklist must be there. And that also can be done by a very well-trained technician. Yes. So for example, at my place, very often, by the time I come anywhere on the screen, anywhere on the scene, my nurse has already made a note whether the child has had an MCU, whether a renal scan was done, if the creatinine is showing a rising trend. Is this child capable of giving a voiding diary? If yes, has the voiding diary been done? Is the child on antimuscarinics? You know, all of these things must happen at autopilot level if you are a tertiary referral center, so that there is no question of missing out on any of these points. And in fact, if you have a well-trained technician and a nurse, very often you may miss out on some of the points, but they will not. Trust me. So the trick is in having a highly dedicated team which is going to stay with you and not keep on changing every few months, because in that case you are the one who's going to be sitting and doing everything from scratch every time, and that is quite tiring. Yeah,
I think yes, that's the way forward, because you have, as in operation theater also, we have a pre-op checklist, WHO checklist, etc. So any procedure would require a proper checklist and an SOP prepared before we do it. So that's
no, I'll give you something very simple. There's so many times that my nurse would send away somebody who's come for a UDM, because there are people who have a habit of writing urinary incontinence advice urodynamics. So before I come in the picture, she will sit, she will counsel the patient or the relative that these are the bare minimum things required. I'll give you a new appointment. Please do all of these.
Right.
And so there is no question of saying that, no, we did the urodynamic, but there was no urine report available, or we had no sonography. No, if you want to come out with quality material, these things have to be done. So it has to be ingrained in the heads of everybody who is controlling the urodynamic scene at your setup.
So you need to have a proper trained nursing staff.
Yes.
That's
yeah,
very
I mean, I entirely agree with what Dr. Anita is saying. Only thing is that, sometimes it becomes really difficult. Patients come from far away and outstation and so on. So obviously we have to be pragmatic and judicious, but you must recognize what is there and not there. In addition to what we discussed, there is another role actually for your staff and support staff, and that is actually in terms of getting, let's say, all of our patients have records of patient-reported outcome measures. So all of our, let's say lower tract symptom patients give a record of male LUTs or female LUTs ICI questionnaires, which are long questionnaires. They're like 22, 25 questions. They do a 6-question UDI 6. Our neurogenic patients do a 25 or 26 questionnaire, patient reported outcome measure on neurogenic bladder. And this happens for all of our patients, a quality of life single question answer. And it all gets captured into the report as well as in our database. So all this takes time and effort. So somebody needs to sit down with the patient, record all this, and then combine that with the study, so that at the end, when we actually have the information, we have the entire clinical information of the patient, including the patient-reported outcome measures.
So again, such kind of ideal situation may not be possible everywhere. So what do you think? Because urodynamics in any way, it's an expensive investigation, it's a time-consuming, it's a cumbersome. And you may not get a good result if you do not have a very dedicated team. So what about the non-invasive urodynamic studies? And what do you think could be the role of non-invasive urodynamics in future? Like the ultrasound cystodynamic about the bladder wall thickness, the bladder weight, and the IPP. And then we have other things like penile cuff, and there are urethral devices, and even Doppler ultrasound to measure the intravesical pressure. So what do you think could be role? Because they could be more simpler, non-invasive way to at least we can select a very specific population where we need to go to an urodynamic. Yes.
The thing is, for most of most of these are applicable to men rather than women, and the information that you get is at this point just, I don't think it's really good enough. You don't have good clinical correlation and so on. For the high risk groups where you are looking actually at safety and so on, you don't have. I get a feeling that at this point we are just not there in terms of non-invasive pressure measurements. But the rest of the things that you said, so when you use the term urodynamics, people use the term urodynamics in a very global, overarching sense of any kind of test which gives you an assessment of dynamic lower tract function. In that sense, even a bladder diary is considered a part of urodynamics. But it's in that global overarching sense, you get a wealth of information from the ultrasound scan, the MCUG, talking to the patient, patient, a good clinical examination, the bladder diary and so on. But I think there are some situations where you just can't do without. And I think when residents, as a resident or, as a young clinician, when you actually work with urodynamics, you're able to get an idea of where you can manage without. The thing is, to be able to understand where you can do without it, your eyes get open when you use the test as a part of your training. There's some clinical situations, there's a kind of plus minus whether you should or should not use, but there are many situations where you just can't do without it. And those situations where you can't do it without it, it's better to refer the patient and get the urodynamics done from somebody reliable than to manage the patient without it. So patient has mixed incontinence, has storage symptoms, stress incontinence, and you want to operate, you must get a urodynamics. Your patient is a young patient, 45 years old, you're planning to do a bladder neck incision, must do a urodynamics. Patient has high risk neurogenic lower tract dysfunction, must do urodynamics. I mean, those are situations where saying that I don't have it is not enough. So I think a patient is your Parkinsonism, oblique multisystem atrophy, you're planning to do a surgery, must do urodynamics. So these are situations where you can't do without. And but there are some places where you can probably counsel the patient and you can tell that if this is the finding, these are your odds and what do you think you want to do? And that's fair enough.
All right. I think,
Dr. Shivam, can
Yes.
I just add something?
yes,
There
please.
is a tendency to say that this is an invasive test, it's an expensive test, we don't have it available at our place, and hence there is a justification for not doing it. But then urodynamic is far cheaper than doing a wrong surgery. Urodynamic is far less invasive than operating on somebody when it is not indicated. And so let us, as soon as you put that filter, and as Sanjay has very rightly said, yes, your center may not have it, but in those isolated patients where you need it, rather than justifying why we didn't do it because we didn't have it, please send the patient somewhere, because at the end of the day, you want the patient to do better, isn't it?
Right.
And so to justify not doing it because you don't have it, instead, yes, do your best to work up the patient with clinical applications as much as you can. But there will be that group who will need it, as Sanjay has emphasized, come what may. And there is indeed, it's non-bailable in certain situations to not do it. So as
Right.
long as we understand that, that's fine.
Yeah, you rightly said that, yes, there are a specific group of subset of patients who definitely require urodynamic study. But
And
again,
Shivam,
yes,
yeah,
Dr.
I do
Dr.
I do
Sinha.
remember that about 25 years ago when I started was thinking of deploying a urodynamic department. I spoke to all my colleagues in one large meeting that do you think it's a good idea to have urodynamic evaluation, urodynamic investigation center in our city? And most of them said that we are carrying out well without it. Why bother? Okay. And anyway, I was determined in somehow to start it. And let me tell you, from the day it started, the same people who say we don't need it have started referring the patients back to our center. That's how the whole scenario changed. And I think you should look for changing those scenarios rather than finding justifications of that we don't have this particular facility in our region.
Soch badlo, desh badlega.
Yes, there is definitely
You want to change, be the change yourself. Yeah.
there is a requirement of urodynamic, there's no doubt. But there are people who would probably would not do a proper clinical examination or a proper history taking, and even the voiding diary. I think how many of us usually do a regular voiding diary in patients, which is probably can give you an ample amount of information in many patients. So Dr. Sanjay, do you think that voiding diary should be made mandatory in most of these patients with lower urinary tract symptoms? Because definitely it can give you a lot of information.
So, my usage of the bladder diary has gone like this over the years.
Right.
And now I would say that it's really, if you have to do good quality management, you must have it. And not just must have it, there are situations where the same patient does it more than once. By more than once, I don't mean more than one day, on more than one instance in their management. And so even my online patients and all, everybody, so they all get a message to contact my secretary on this number to learn how to make their bladder diary, even if it's an online consult. So I think a bladder diary is critical, especially for storage. but also for storage with voiding dysfunctions and a whole lot of others. So just one example to show you the critical importance of the bladder diary. In the last 8-9 years, we have picked up, I think, 19 patients with diabetes insipidus related upper tract damage, where a simple bladder diary was never done. And they've had a whole lot of investigation and DI not picked up. So as a urologist, I picked up DI in some 19 patients. And these were patients with urine outputs of 7, 8, 9 liters. I can tell you now, I can spot this when the patient comes. And, it's almost like a sixth sense, which tells me that there's a problem with the bladder, with the urine volume. And you'll be surprised how critical volume can be in the findings that you get. So the large, even if the patient doesn't have a DI, substantially large urine volumes can actually grossly alter the morphological impact of the same lower tract dysfunction. So the same level of lower tract dysfunction, and one patient who habitually produces 3 liters a day for the last 20 years, and the other who produces 1.25 liters a day for 20 years, you will find difference in the morphology of the urinary tract. And this is something that is not there in textbooks, but it's important to understand, because sometimes you're puzzled, why is there upper tract change like this? Why is this particular thing happening? And unless you actually look into this aspect of the patient's management, you will not be able to pick these problems up.
You're right. Well, we can, there at least in patients with nocturia. Nocturia.
Oh, nocturia, it's absolutely mandatory.
Pardon?
Absolutely mandatory.
Absolutely mandatory. And we are not in a habit of doing avoiding diary. If you do a survey, I think only 5-10% would be probably using avoiding diary. So I think we should stress upon this fact also, that it is very important to avoiding diary. So before we wind up, we will just try to, like in one of the Paul Abram's lecture also, I heard that the future of urodynamics and functional urology, we have, like in urethral pressure profilometry, we have almost abandoned in last few years. And what he is saying, that the way we are doing is probably not the right way. And there are many patients who have urethral instability, he says, and urethral hypertension. And that can be picked up if you do a proper urethral profilometry, and that they can be managed properly if you do, if you can actually get these patients. Those who do not have any bladder changes, but they have some urethral changes, which can be missed if you just simply do a simple urodynamics. Yes.
So to answer your question, so UPP obviously is not a regular UDS tool. We have UPP in our machine, and we sporadically use it, but we are increasingly incorporating it into some subgroups of patients. So there are some patients, so the urethral instability part is a plus minus for me. So the main situation where I think the UPP has some potential use is patients in whom we suspect that some form of urethral, you can say, pelvic floor dysfunction or sphincter dysfunction is reflexly inhibiting a bladder contraction. So if I have that kind of thing in mind, it's a subgroup of patients. That's a group of patients in whom one may think of doing it. From a practical perspective, what difference does it make? There might be some difference in these patients, because if you can get the sphincter spasm or the pelvic floor spasm to come down, maybe they'll be able to initiate a detrusor contraction. So that's one group of patient in whom perhaps there is a potential role. And this is the group of patient in whom actually there is more of a comeback of UPP in specialized centers. Otherwise, it's a question of training. People who are trained as urogynecologists, typically by gynecology departments, tend to do the UPP, and people who are trained in urology units don't use the UPP. But most of the guideline documents that you see, they don't have UPP at all anywhere figuring in the guideline documents. So none of the guideline documents actually you don't have guidance with regard to UPP findings, because they're not really that standardized in terms of their utility. But there is, one must recognize that there are patients in whom the UPP can be useful, and it's a good research tool, especially if you're working in the area.
Yeah. And another thing,
Dr. Shivam, can I leave with your kind permission? Thank you so much. Thank you, Sanjay. I'm so sorry, Shirish, I'm interrupting.
No,
but I have to be elsewhere.
This is
I have to be elsewhere at 8:30. So thank you so much for asking me. And Sanjay, as always, you've done a wonderful job. Thank you so much.
Thank you, Dr. Thank you.
Bye.
Thank you very much. So I was just, when I was just going through one of those presentations of Dr. Paul Abrams, he said that one of these patients who had this urethral instability, when treated with neuromodulator interstiments, it was managed very well.
So what the answer to that would be that many of these conditions which you are talking about, the sacral neuromodulation is a blunt instrument which actually is widely applicable in terms of you can try using it across many of these conditions, and you don't need a UPP to do it. I mean, so let's say if a patient has unexplained voiding dysfunction, and you have, let's say, pelvic floor dyssynergia, let's say, for instance, you don't need to do a UPP to decide to use sacral neuromodulation. We know that whether or not you use the UPP, about 40-50% of them will have some improvement with use of neuromodulation. So really, whether the UPP actually would trigger my use of the neuromodulation, I don't think so. If the patient is able to afford it, I would plan for the sacral neuromodulation regardless of the findings. But there are some situations where I think it is definitely of benefit, and I would use it in those situations. So patients who have this, overactive bladder type symptoms, and you feel that it's a urethral instability, and this is again a disputed entity altogether, it's not there in any of the guideline documents, then anyway, for refractory OAB, neuromodulation is a part of the treatment, right? But there's no data to show this so-called, there's very little data on it, so let's not get into that territory. But yes, UPP does have some limited role.
All right. So any last comments on what is the future of urodynamics?
One comment I would like to say is that I think I was a little rushed in those 35-40 minutes, and each of the conditions that we've actually discussed are themselves worthy of a full hour's discussion. So we did, for instance, recently for Colombia and South America, I did a whole 1.5-hour session just on DSD, just right. One finding. So, I mean, it's possible to have a discussion in depth on any one of these aspects. So I recognize that a whole lot of stuff that we have not covered today, which is worthy of being covered. But you're all residents. I'm sure you're reading much more than we ever did. And you actually have a lot of information that we don't have in our heads right now. So you can probably incorporate it all there. Rest, I think from the one message that I would like to leave everybody is with that in a neurogenic, especially bladder dysfunction, neurogenic lower tract dysfunction, storage pressures are critically important. If you can just keep this one thing in mind, I think you will save a lot of your patients from getting into renal failure and perhaps even dying.
Thank you, Dr. Sanjay. Dr. Shirish, any last comment from your side, and then we will wind up. Dr. Shirish? I think there is some signal problem.
I think we lost him.
We lost him. So there's some. So thank you, Dr. Sanjay.
I must thank you. It's a real pleasure.
It was a real pleasure to have you, and really honor. And I think that the residents must have benefited a lot. And then later in future, we definitely look forward to have a longer kind of workshop kind of thing on urodynamics, and we will surely do it. Thank you very much. Thanks a lot.
Thank you. Thank you so much, Dr.
And good night.
Good night. Good night, everybody. Good night, everybody.
Good night.